So for the next hour, and we have obviously a pretty important deadline on the backside of this, we've really got three extraordinarily distinguished speakers who are going to talk to us about a variety of facets of vascular disease. So let me invite Professor Maaret Venermo to come up to the podium. Professor Venermo is the head of the Department of Vascular Surgery at Helsinki University. Finland's supposed to be the happiest country on earth, so we'll see. Her research concerns registry studies aiming to evaluate the quality of vascular surgical service, as well as the international variation in practice in critical limb ischemia and the epidemiology and natural history of aortic iliac aneurysm. She served as the chair of many different societies and boards. Her current main title is she's the General Secretary for the European Society of Vascular Surgery. I think that means she's the one who actually does all the work for the society. And what she's going to talk to us today about how screening affects elective surgery and emergency surgery. Maaret, thank you for coming.
Thank you very much for the kind invitation and kind introduction. And it's really great to be here. It's warm and humid. I'm talking about screening and how it affects elective surgery and emergency surgery of AAA. Here are my disclosures. So Finland and Sweden are a part of Nordic countries. They are quite similar countries. We have common history. Finland has a population of 5.6 million and Sweden 10.3 million. We don't have screening of AAA in Finland, and in Sweden there is national aneurysm screening for men. We both have mandatory national registries. So Institution of Health and Welfare register all surgical procedures and hospital episodes. Cause of death registry register all deaths, including cause and date of death. Combining data from different registries is possible with personal identity code. And indeed, they started national screening program for abdominal aortic aneurysms for male 65 years of age, one-time screening in Sweden in 2006. So we used these mandatory national registries and gathered all abnormal aortic aneurysm and ruptured aneurysm repairs performed during 20-year period from 1998 to 2017. And also we gathered all deaths during the same period because of abnormal aortic aneurysm or ruptured aneurysm. And we had altogether 23,000 elective aneurysm repairs and 9,500 ruptured aneurysm repairs. So what impact screening had to the rate of non-ruptured abnormal aortic aneurysm? Here we can see the orange line is Sweden, and from 2006 onwards we can see that the rate of elective surgery increased about 50%. The blue line is Finland, and we can see that there is pretty much no increase or decrease of the repair rates. How about ruptured abnormal aortic aneurysms? So in the right-hand side you can see the orange line, and it is Sweden, and we can see clear decrease. Actually, the repairs for ruptured abdominal aortic aneurysm decreased 75% during the 20-year period, and most of this decrease happened after implementation of screening. And in Finland we can see that there is also a little bit decrease, which is not very significant, but most probably due to the improved ultrasound and more CTs to the persons for other reasons. And here we can see the repair rates in two age categories, 65 to 8 years and over 8 years. And indeed, in Finland, the blue line in the left, we can see in men that it's actually decreased a little bit, the elective surgery rate, when the orange line is Sweden, and we can see the increase caused by screening. And then in the right, we can see the repair rates in first men over 8 years and clear increase in both Finland and Sweden. So I think that this increase is not because of screening, but again, because of more ultrasound, more CTs for other reasons to these men. And in the bottom, we can see the rates for women. How about the age distribution? Here you can see the age distribution before the screening was implemented. In Finland, the mean age of men was something like 72 years and a couple of years higher in Sweden. After the screening, here top is Finland, no big difference in mean age. However, we can see a clear peak in Sweden in men aged 66 years of age. So these are the aneurysms that were found in screening and repaired. So these are the rates for repair for non-ruptured and ruptured aneurysms in both countries. And when we combine these two, we can see that actually the total aneurysm repair rates was quite constant, no big difference, a little bit decrease. The only thing what happened was that actually in Sweden, the proportion of ruptured aneurysm of all aneurysms decreased from 43% to 16% during the 20 years period. Let's go to this figure again. So these are the rupture rates in male and females. And usually the women's curves, because the incidence of aneurysm is so low and prevalence, it's difficult to see differences because usually the scale is adjusted to show men who have much more aneurysms. But if we divide these two curves, we actually can see that in Sweden, which is now blue line in this figure in the right-hand side, we can see that also incidence decreased in women after implementation of screening. Is the reason, these are elective, these are rupture repairs, and we don't, of course, know what is the reason. Maybe doctors became more aware of aneurysms and they were treated more electively, or maybe when their husbands got the invitation, they thought maybe I also have an aneurysm. We don't know the reason behind this decrease. In Finland, it didn't decrease significantly. So this is hypothetical model which has been calculated according to the rates in Finland and Sweden. And the green line is what actually happens. So this is number of operations for ruptured abdominal aortic aneurysms in Finland. And the red line is, since if we had implemented the screening in 2006, according to the numbers we now have from Sweden, what is the hypothetical number of repairs? And we can see that instead of performing something like 90 repairs annually, we would perform something like 40. And in Sweden, this is also a hypothetical model if they hadn't implemented screening. The green line is what is actually happening, and they are having screening a decreasing trend. So red line is the hypothetical model, and instead of performing something like 120 repairs annually for ruptured aneurysm, they would maybe perform 220 according to this hypothetical calculation. And what is very nice to see is that the 90-day mortality have decreased over the 20-year period, maybe because of implementation of ERA, maybe because improved care of these patients or intensive care. And we can see first figure A is elective surgery in both countries, B is ruptured aneurysm surgery in both countries, and C is combined mortality, 90-day mortality in both countries during 20-year period. So in conclusion, after screening, the elective repair rate in men increased 50%, and we could see a clear peak in Sweden at 66-year-old men. At the same time, repairs for ruptured aneurysm in men decreased for 75%, and also in Sweden, where the screening was implemented, rates for women decreased about 30%. Combined non-ruptured and ruptured aneurysm surgery rates remained constant in both countries, and outcome of abdominal aortic aneurysm and rupture repair has improved during the last 20 years. And in the end, I took some liberty to compare Finland and USA regarding the biggest risk factors for aneurysm. And we can see that actually in both countries, smoking has decreased during the last 10 years, and it's 14% proportion of active smokers at the moment in both countries. How about hypertension? The biggest risk factor for hypertension is salt intake, and we can see that in both regions, it's actually the double consumption of salt is actually double, which is recommended by American Heart Association, and almost double compared to a recommendation from WHO. And as in all over the world, here and in our country and pretty much every country, people think the salt intake is satisfactory, so it's a light blue color, and the dark blue is the proportion of people who think they take too much salt. So this is very difficult issue to touch or influence, because that is the common perception. And this is pretty much my last slide. This is cholesterol, and we can see here cholesterol levels in different animals, and then we can see cholesterol levels in these populations who live naturally, who don't intake salt, and they eat very little saturated fat. So the physiological levels are 58 milligrams per deciliter, and these people have this kind of LDL level compared to 131 in Finland and 126 in USA, which is far beyond the high-risk patient level. And also the blood pressure levels are higher in our countries. And I know that you have targeted screening, which is really great, and I would like to know how effective, is it as effective as this population-based screening, that every single man are invited? And I would like to know it, because we tried to implement this screening in Finland, and unfortunately we don't have it yet. So thank you so much. It's really great to be here. It's warm. I was swimming yesterday. It was really warm, the seawater. This is from our summer cottage a couple of days ago, so we still have to wait before we can swim. Thank you very much.
Merit, thank you very much indeed. That was spectacular and exactly what we want to hear in terms of what we can learn from other countries. So we're going from the happiest country on the earth to what I think is the happiest guy on the earth, and that is Dr. Santi Trimarchi. He's always smiling. And he comes to us basically from Milano. He got his medical degree in Messina, did vascular surgery at the University of Milano, and he's now gone back there. He trained in what I don't even know what it is, thoracovascular surgery, and did a research fellowship in aortic disease at the University of Michigan. And so he's been back in Milan for a long time. It's one of the stalwarts there, and has also been really one of the drivers in the IRAD, the acute aortic dissection registry. And he's going to talk to us today a little bit about update on acute aortic dissection management. Santi, thank you for coming.
Thank you, Alan. Good morning to everybody. Thank you to the society. That's a really privilege to be this morning here to give this speech on update on acute aortic dissection management. So when we talk about acute dissection, let's start a bit from type A dissection, where the situation is clearer. This patient needs to be treated with open repair, and this has been associated over the time with an improving results. As you can see, the trend And actually, the mortality for acute type A dissection is a bit over than 10%. And the reason is because in this setting have been introduced a different procedure like cerebral and brain protection. If we talk about the ARCH, situation is a bit unclear. We have this consensus from the European Society of Cardiothoracic and Vascular Surgery that says for ascending involvement, open procedure is mandatory. But there are also cases with no ascending involvement, named non-A, non-B. In this case, the way to go is conservative or case-specific approach. And we do not have indication for the ARCH related to the last ACC/AHA guidelines. As well, we do not have indication if we look at the AATS guidelines recently published in 2022. But we have data, single-center data from Fribourg group that say that open approach is needed when ascending involvement is present, and no ascending involvement is associated with patient-specific approach, which is exactly in line with other data that we have from the IRAD registry, where we named those patients with the proximal entry tier into the ARCH, but no ascending involvement as ARCH-B. And we noted that the tendency to manage this patient is exactly the same as a patient-specific approach. If we talk about type B dissection, we have more evidences. First of all, we have a consensus. It's a reporting standard. This is very important, published on JVS in 2020, which include both vascular and cardiac surgeons. These are not guidelines. This is the reporting standard on nomenclature and classification. And this is very important because in this way, using this methodology, we can talk about the same patient with better definition in terms of proximal and distal extension and eventually involvement of target vessels. And we have also an aortic dissection acuity definition. We have complicated and complicated high-risk patient. And this has been exactly the same that the cardiac surgeons adopted for their last guidelines that I already mentioned, AATS 2022. So also in this case, the division, subclassification of this patient is exactly the same. So I would like to say that the cardiac surgeon, specifically for this point, followed the mixed group of vascular and cardiac surgeons. And then we end up with the even more recent guidelines from AHA-SCC, published at the end of 2022, where we have exactly the same definition of the acuity of such patient, with in addition a better stratification of those that defined as high-risk clinical findings like refractory hypertension, refractory pain, when these patients are exactly included in such context. And we have also an additional definition of malperfusion syndrome when these involve cardiac, cerebral, spinal, or peripheral sections. Let's talk about complicated, means those that present with rupture and malperfusion. These are patients named as acute complicated. There is no doubt today, 2023, that TEVAR is indicated for managing this patient. But interesting is to see that it's mentioned favorable anatomy for TEVAR. And the level of evidence, a class of recommendation is 1B. Open repair can be considered when this anatomy is unsuitable. And this is exactly what the ACC/AHA guidelines mentioned. Means, one more time, treat this patient with the TEVAR with the same class of recommendation. If we talk about uncomplicated, situation change because there is a lot of debates how to manage this patient, beside the fact that we approach initially with medical therapy. Then we have a prophylactic TEVAR that may be considered, and 2B is the class of recommendation based on AATS guidelines, which is exactly the same that was already showed by the European Society of Vascular Surgery in 2017 and also more frequently, as I said. In what we noted regarding this class of recommendation, that this shifted from 2A in 2014, proposed by cardiologists in the European Society Cardiology Guidelines for Aortic Disease, to 2B in 2017, 2B again in 2022 from AATS, and confirmed by ACC guidelines 2B. It means we treat this patient when some situations are present from clinical point of view, but also from anatomical point of view. A couple words also in terms of optimal medical therapy, also for those patients who have a retrograde extension dissection into the arch, means treat this patient in a conservative way when this is possible. And if we look a bit more regarding the cohort of uncomplicated patients, I like to say that this cohort exists because there is a lot of discussion that say these people, when are affected by type B dissection, they dilate over time and they need management. This is true, but let me say this is partially true. We have at least 4 different evidences that uncomplicated patients exist. These 4 are reported over here. As well as if we look a bit better in some important and recent publication on patients with type B dissection who dilated over time, it's interesting to note that when the authors say that 38% of medically treated of uncomplicated required an intervention at the aortic level, I like to think that the rest, means 62, did not require. That is similarly to the MGH analysis was performed at Emory. So more or less 50% dilate, but 50% did not. If we look at the TEVAR usefulness in such setting, we have a very recent paper from the GREAT registry, published 1 month ago on JTCVS, that say that when we treat this patient with the TEVAR, risks are no higher. So we have another small piece into the discussion, means is useful, is unuseful, which is the risk. The risk seems low if we lead at this data. However, we have important and upcoming trials in such context from US and from Scandinavian area that will clarify this point. Couple words also related to connective tissue disorder patients. This should be treated with open over TEVAR when this is possible. However, TEVAR can be a bridge. This is one of our cases that we managed in this way. And I would like to say even more evident for chronic patients. When we have a chronic post-dissecting aneurysm, we tend to try with a TEVAR approach. This can be useful in 1/3, 1/2 of the case, but most of the time is a TEVAR as a bridge because need a revision complete or partially, depends what type of lesion the patient is going to develop. So for chronic, probably open still remain the best options. In terms of changing pathology, which is the best time when approaching these patients, clearly, we have indication for not treating uncomplicated in the very acute setting because the risk of having complication is higher. So we prefer to shift into the subacute or initial chronic setting. These are unpublished data from the IRAD registry that have been submitted very recently in this week. We are talking about almost 4,000 type B dissection is a trend analysis over 20 years span time. And you say that in terms of management, endovascular approach now is becoming more important than surgical for sure, but is approaching medical therapy. But it's more interesting to look at the in-hospital results where overall mortality also for Bs following As, as we said in the beginning of the presentation, also for Bs, mortality is decreasing. And is decreasing regardless the type of approach that we adopt for this patient, medical, surgical, or endo. Maybe we are going to select better our patient and our treatment strategy. And results are in line also if we look at 3 years follow-up, means midterm. Anatomical consideration. That's an interesting point that personally we love as a group, that we do research specifically in this point. Also because the concept of anatomy was not mentioned, for example, in 2017, in the last European guidelines for thoracic aortic disease. No definition about anatomy for B dissection. Similarly, we noted the same in the AATS, and the situation changed because now anatomy is clearly mentioned in AATS and AHA, ACC guidelines, because we always face with such patients presenting with favorable or unfavorable neck for standard TEVAR. And we believe that this point is of importance. And the importance is related also to the forces that act at the level of the arch. This happens both proximally and also distally. We have an increasing literature specifically related to bioengineering analysis on such issues, and these have been associated with an increasing risk of complication, named like retrograde B dissection, stent-induced new entry, or a type 1A endoleak. And this data comes from a couple papers. That's an interesting analysis from Padua group in Italy that mentioned that in presence of type 3 arch, our proximal neck length should be a bit longer, not 20 millimeters as reported up to now, but should be longer because the risk of having a shorter one is associated with the risk of complication, and they noted this problem exactly in line with our previous multi-center analysis that showed that in the hostile landing areas that are zone 2 and 3 of arch type 3, the proximal TEVAR failure was much higher, 21%, compared to those that had a different arch, 5.3%. This means that if we have patients like this is a case of PAU that we treat with a regular standard TEVAR, we should shift more proximally following such approach. But this is not so safe in all cases because additional proximal sealing may require additional debranching. Additional debranching means more complex procedure, so increasing complication that can be present. In the same setting, we know that arch type 3 has an increasing forces. So what we do, how we can manage this situation? We need to maybe follow case by case, look at the forces, look at the patient, look at the age, look at the materials that we have. But for sure, complex anatomies that require more complex procedure may be associated with higher risk, as I'm trying to show you right now. We use this knowledge, new knowledge, also in daily practice. This is a patient who came to us with the peculiar type E dissection, proximal entry tear in the very distal descending aorta with the retrograde dissection involvement and intramural hematoma up to zone 3. Based on these forces, on this analysis, we decide not to start from an safe proximal neck where disease was not present, but we deployed the stent more distally in a parallel aorta. So we shifted our approach from an angulated area to a parallel area based on the force that we analyzed. Probably we were lucky, but we fully believe that the parallel aorta can be useful for such purposes just because forces in the angulation may be associated with increased risk. This is my personal experience for acute dissection A and B over my life. And let's come to the conclusion. For sure, now we have a better definition of acute aortic dissection if we compare our knowledge today with only 10 years ago. Now we have a better definition of acuity of disease, better definition of the anatomy. We have specific guidelines that address such point. And I like also to underline the role of the vascular surgeons in this field. Disease type B dissection are not only managed by cardiac surgeons, or let me say cardiologists when these need to be managed automatically, but vascular surgeons play a strict role. Vascular surgeons are in the first line of the reporting standards. Reporting standards, as I told you, was exactly integrated and used by cardiac surgeons in their guidelines. And also I like to underline the role of the vascular surgeon within the AHA-ACC guidelines. We have colleagues that are really in the first line of such important document, like James Black as in the writing committee members and Mark Sherman, which is SVS representative in such a document, and my friend Guy Babchurch as vice chair of peer review committee members. So vascular surgeon really matters and really play a role in such setting. I like to underline this. Looking at definition and look also at the management, it's clear that complicated can benefit from TEVAR. In uncomplicated, we have upcoming trials, but we can consider TEVAR also in this setting. Of course, the role of the anatomy looks as very important. Treating or not this patient with the standard procedure or not really matters for the patients, and we know more also about the forces that act at this level. And I like to say thank you again to the society, to Dr. Lamsden for the very kind invitation, and to all of you for having given me this privilege. Thank you very much.
Thank you, Santi. Yeah, have a seat up here. He's actually joined by two of his research fellows who are sitting in the front row, and they're actually currently spending time with Dr. Schimmerhorn and Dr. Upchurch. So thank you for those relationships. So next up is Dr. Daniela Branson. She's went to medical school in Romania and trained in vascular surgery in Freiburg, and she's an associate professor who leads the division of vascular surgery at the University of Leipzig. And that's a key area, basically, particularly in the lower extremity world. But she's extensively published not only in PVD but in aortic disease, was recently interested in COVID thromboembolism. But what she's going to focus on today is when should EVAR be considered successful? I guess that's the hot topic of the moment, huh?
Yeah. Thank you, Alan, for the kind introduction. It's an honor and a great pleasure for me to be here today. And I will try during the next minutes to answer the question, when should EVAR be considered successful? As we know, the endovascular treatment of infrarenal AAA had tremendously developed during the last decades with the optimal goal of exclusion empty aneurysm and preventing aneurysm-related rupture. But as we know, the long-term related complications after EVAR are not negligible, and thus the success after a long time follow-up might be compromised. As you can see here, the most frequent complications of EVAR in long-term follow-up are the endoleaks. And the persistent blood flow between the stent graft and the aortic wall within the aneurysm sac is one of the main reasons for further growth of infrarenal AAA after EVAR, which might cause rupture and death. Very important to look at the outcomes after EVAR is to look at the aneurysm sac behavior. As you can see here, in a cohort of roughly 600 patients, the early changes in aneurysm sac diameter were a strong predictor of lung complication after EVAR. As you can see here in Kaplan-Meier curve, the patients with no sac shrinkage had significantly more secondary interventions than those with moderate and major shrinkage for up to 5 years. But not only the interventions were associated with sac, also, as you can see here in the VSGNE registry of roughly 800,000 patients, aneurysm sac diameter increase of more than 5 millimeters at 1 year was independently associated with late mortality. But very important, in the VQI registry, you can see here more than 14,000 patients were looked at. The patient with SAC failure to regress had lower long-term survival than patient with regressed AAA SAC. Thus, not only SAC decrease, but also it's the most important parameter to look at the aneurysm SAC. That's why the aneurysm SAC regression should be considered a new paradigm for success after EVAR. But what are the predictors for SAC enlargement? As you can see here, a recent publication in Circulation from the Japanese Working Group on Aneurysm looked at the results of more than 17,000 patients treated with EVAR for their infrarenal AAA. As you can see here, the most important predictor for SAC enlargement was found to be type 2 endolink. Besides that, the advanced age, the male sex, the proximal neck diameter, as well as the chronic kidney disease were considered a predictor of SAC enlargement. Due to the importance of type 2 endolic in this cohort, let's have a closer look what this type 2 endolic can cause. The same paper showed us the negative correlation between the presence of type 2 endolic and the adverse event after EVAR. You can see here the patients with type 2 endolic had a SAC enlargement, and also they had an increased aneurysmal rate in mortality. What is type 2 endolic? We all know it can be simple and it can be complex, one branch, more branches. And roughly the published incidence, it's 22% in a pooled meta-analysis. And they are well-known risk factors, but also not so well-known risk factors. You can see here the patent inferior mesenteric artery, the patent lumbar arteries, and the maximal aneurysm diameter have been considered a risk factor for type 2 endolic, and the smoking is considered as a protection of type 2 endolic. You can see here the freedom from aneurysm sac enlargement for more than 5 millimeters at 5 years was 76% in patients with more than 4 lumbar arteries open to the sac, and 89% patient with less than 3 lumbar arteries. Also, inferior mesenteric artery plays an important role on the type 2 endolic. As you can see here, the freedom from aneurysm sac infarction at 5 years was lower with the patient that had a patent EMA in comparison to the patient that had an occluded EMA. Another study here, very important also from Japanese, looking at patients with and type 2 endolink, also demonstrated that type 2 endolink is a significant predictor of SAC enlargement during long-term follow-up. And also very important, another paper showing that the type 2 endolink, it's a significant predictor for aneurysmal-related death after EVAR, so death caused by type 2 endolink. Let's look at the European guidelines. What do they tell us when we have patients with type 2 endolic? The European guidelines only indicate the treatment of type 2 endolic in case of SAC enlargement. As you can see here, expansion of SAC of more than 1 centimeter during follow-up. And this intra-intervention should be mainly performed endovascular, embolization of aneurysm sac, conversion to open repair, and also laparoscopic plicking. But there's enough data publications showing that the recurrence of type 2 endolic after 3 years after this procedure is more than 50%. Thus, you might conclude that our patients need continuous surveillance, continuous monitoring to detect further aneurysm curve, further type of endolics, and thus increase the radiation and the total cost of infrarenal AAA treatment. That's, we have asked ourselves, is it not better in this case to prevent the type 2 endolics? So far, we have developed 2 types of prevention methods of type 2 endolic. As you can see here, on the left side, the sac embolization with coils, and on the right side, the preventive embolization of side branches of the aneurysm sac. When you look closer at the sac embolization, there are some disadvantages. As you can see here, after you place the coils in the aneurysm sac before EVAR, you can not detect an immediate occlusion of the type 2 endolic. It's still present on your final angio, and you ask yourself if the treatment has been successful. Furthermore, if you look at this patient during follow-up, you can see here on this example of the CT, you can see on the CT a lot of artifacts, which renders your judgment about your infrarenal AAA and the success of the treatment very difficult. Thus, in our center, we have adopted the second method of side branches coiling of the aneurysm sac to prevent type 2 endoleak. And we started that almost 10 years ago in 2014. And of course, we excluded from this method patients who needed an urgent treatment, patients who had renal insufficiency, and we could not give them enough contrast media. And of course, we have not looked at the patient where the lumbar artery were to be covered by the stent graft. And you can see here altogether we were able to look at the data of almost 140 patients in our center. You can see here on the right side, they are very typical comorbidities of an infrarenal aneurysm cohort. Of course, the coiling technique of the side branches of the aneurysm sac is not always trivial, but we most of the time when we have difficult cases, we use some kind of fusion imaging, as you can see here, AI-based Sider fusion imaging to coil the inferior mesenteric artery. And our goal is to coil as many side branches of the aneurysm sac as possible. You can see here we begin proximally at the level of L2 when needed, when this one would not be covered by the stent graft, and we can down at the L3, and you can see here an example at the L4, and you can see here a final result where in this patient we coiled 6 lumbar arteries and the inferior mesenteric artery. You can see here in our retrospective data, we were able to occlude roughly 80% of our inflow to the aneurysm sac with almost no complication. This cohort, so far, we were able to follow up to almost 2 years, and you can see here we have a 5% present of endoleak type 2, which is a lot lower than the 22% present in the pooled meta-analysis. And this incidence kept up during follow-up, and you can see here the mortality in our cohort was 81.8, the freedom from mortality 81.8%. Very, very interesting. You can see here, we looked at our data, almost 2 years of follow-up. We had a dramatic decrease in the aneurysm sac. As you can see, a 56.6 millimeter the presentation, and after 1.9 years, we have 48.9. And we can look at the number of patients who had the sac increase. You can see here that 86% of our patients had an infrarenal AAA regression only after 1.9 years of follow-up. Very interesting. We have looked at the data published so far, and you can see here the number of patients who had a regression in our cohort is double than the patient that were presented in the VQI registry, larger than the registry VSGNE, and larger than the ENGAGE registry. You can see here 7 patients had a staple diameter, and 7 patients, those were the patients who had a type 2 endoleak, they all presented an increase in sac diameter. So after this experience, I can conclude that the preventive embolization of aneurysm sac side branches in patients with infrarenal AAA is safe and effective in preventing the type 2 endoleak after VBAR. And the shrinkage of aneurysm sac, and thus successful EVAR, in my opinion, was observed in a high proportion of our patients. But of course, as we know, the definitive evidence for routine embolization of aneurysm sac side branches to prevent type 2 endoleak after EVAR and promote shrinkage of the aneurysm sac and then have a successful EVAR treatment requires a randomized controlled trial. We are now currently planning. Well, thank you for your attention, and I hope I have partly answered your question.
Well, that's a little controversial. So we still got about 15 minutes for questions. So please step up to the mic and ask some questions. Let me kick it off by asking Merit. So tell us a little bit about the screening process. In the United States, you can't get 100% of people to do anything. And so how do you manage to encourage the population to be screened? What age is it? And then what are the criteria for doing the intervention?
Yeah, so as I told you, we don't have the screening in Finland, but I do know that what is the system in Sweden. So they invite males when they turn 65 during that year. And it is a study nurse or ultrasound nurse who is doing the screening. I don't remember how many they do per day, but they do a lot. They don't screen anything else but aneurysm. Like in Viva trial, they screen blood pressure and they screen ABI. So in Swedish screening, it's only one time ultrasound to the abdominal aortic aneurysm. I think that the attendance rate has been something like 84 in Sweden. I know that Finnish people, they usually do what they are told to do. So if you invite them, they will come. And you asked the criteria for elective repair. So we have a 50 millimeter aneurysm diameter for women and 55 for men.
Dr. Lawrence.
Yeah, to follow up, Dr. Venermo, that's a great talk, and the only place probably in the world where you could get the type of data that you have is in Scandinavia. My question has to do with one of the arguments in the United States against screening is looking at this thing called QALYs, which is the cost per saved life or per saved rupture. And, you know, there are only a few screening things, mammography, colonoscopy, that meet those criteria. So my question is, do you have the opportunity to look at what we would call QALYs or some sort of financial analysis? Can you tell us what it costs per saved life or per saved rupture to do a comprehensive screening program? And maybe that would be an argument for beginning to implement it in the United States if we had that data.
Yeah, good. Yeah, it's very important. Of course, we have to, first of all, remember that if we screen, we operate these aneurysm quite earlier than we do if we don't screen them, because as we saw from the demography, it was 66 years with great peak. We have not done the analysis on the cost per QALY. I do that they have done in 2 screening programs this calculation. The other one is in Denmark, where they had this randomized trial and implemented screening to the one group and no screening to the other group. And it was something like 15,000 per QALY. I know also that in Great Britain they have done this calculation and their cost was much higher, but I do also know that in UK the attendance rate is lower to these programs. But I think we should maybe calculate here also what it means, because we have now this hypothetical scenario.
Dr. Glowacki.
Well, I enjoyed each of the talks very much. I have a question to Dr. Brunson about embolization. There must be some risk of embolization before placing an endograft into the aneurysm, especially if there is a large amount of thrombus in it. So I wonder if you do this selectively, or what is the tip we need to know to avoid embolization?
Well, basically, it's very important that you cannulate very smoothly the origin of the segmental artery and also the material that you use for embolization. We don't recommend to use a particle or fluid. We just use the detachable coils. There are different type of materials that you can use, and also very important the sizing of the materials that you place in the arteries. Very important is that you place the material at the ostium, so you let the collateral network of the spinal cord intact. So in this series we did not have any signs of iatrogenic spinal cord ischemia, and we have also large experience with segmental artery coiling for preventing spinal cord ischemia. In none of those 2 studies we had iatrogenic ischemia. But it's not an easy procedure, and you can see most of the time we use some kind of fusion imaging to plan the procedure. And basically, before we start the procedure, we look very carefully on the CTAs, where are the ostium located of both the lumbar artery, both inferior mesenteric artery. We look at the calcification, we look at the thrombus load, and we use the neurointerventional technique for embolization, the Tower of Power, where we have a a larger sheath, and inside a larger sheath, a smaller sheath, and then a microcatheter. And with an O14 wire, we carefully canalize the ostium and the artery, and then over the O14 wire, we push the microcatheter, and basically we use the microcatheter compatible coils.
Let me go one follow-up question, first of all, to Daniela. So the counter-argument is that's a lot of money in coils that we're looking at. I mean, it looked like an IMA and 6 lumbars that were embolized in that case that you showed. The majority of those patients, probably because they die, will never need an intervention. And so are you doing this with all of the patients, or are you selecting the younger ones that we expect to be around for the next 10 to 15 years, for example?
Well, you can see the data. They were not all the patients. This is roughly half of our patient collective. And we look, basically we screen the patient with the AAA. When we screen them, we look at the risk factor for aneurysm rupture. So of course we look at the age, not only age, but life expectancy. We looked at the aneurysm diameter. We looked at a thrombus load. We looked at the number of the segmental artery. And we do not call the segmental artery that will be covered by the stent graft, of course. And when we have only one segmental artery patent, we don't touch those patients. So basically, it's a very, very intensive selection of high-risk patients for type 2 embolic. We are a very high-volume center for endovascular for treatment of infrarenal AAAs. That's why we have a large number of patients, but basically we don't get more than half of the patients, and even half, I think it's exaggerated.
Okay, sorry, go ahead.
Tommaso Cambiaghi, UT Houston. On a similar note, historically, to select between EVAR and open surgery in reasonably fit patients, we will see whether we can get EVAR device up and whether we can seal above and below. Now, with all this data about EVAR failure, should we be taking into consideration all these risk factors for early and late failure of EVAR when we consider open versus endovascular treatment?
Thank you. That's a very good question, and we had a small talk during the pause, and I was mentioning that the open surgical techniques should be, the skills for that should be kept, because I see also in our center that we have also a shift toward open surgery, and we tend to treat those young patients more with the open surgery. Of course, both techniques should be available, and you should look at risk factors, and at the end, it's a patient-level decision of whether you do EVAR open repair of your, either you do pre-EVAR coil embolization of the segmental artery. I think it's not only the technique, but it's the patient as a whole that you have to take into consideration when you have your treatment strategies.
Dr. Tomarski, we can't let you off the hook completely. And so I'm kind of interested in, guidelines are great right up until the patient comes through the door and they don't quite fit. So if you have a uncomplicated type B dissection in an 80-year-old, what do you do?
What do? We give medical therapy, for sure. Basically, we maintain the patients in the hospital for 2 weeks. So our practice has been changing in 20 years, always 2 weeks as minimum. During this time, the patient is submitted to 3 different CT scans. One is time 0 when he presents in ICU or comes from another hospital, and then we tend to wait at least 4 days before to go in with the second one, and then we perform the third before the submission. What we are looking for during this analysis is the maximal diameter, if changing, if there is a longitudinal extension of the dissection. These are the things that we do. 80 years old is the regular patient that we see, or we face with 30-year-old, or we face with 80-year-old most of the time. Usually we tend not to treat in the acute setting, but we pose a lot of energy in understanding the risk based on the anatomy. And also there is also the biological question. There is an anographic issue, but there is also a biological issue. We face with the 40-year-old patients in extreme bad condition, and we face with the 80-year-old in a pretty decent condition. Okay. So anatomy drives in the midterm the indication for management.
Do you push the younger age patient towards interventional therapy, or do you treat them all the same?
No, we do not treat all of them. We still believe that the open surgery has a role. We tend to stent younger patients, of course, all of them when they are complicated, all of them when the anatomy is okay, for standard TIVR, means do not think to go in zone 1, at least in zone 2, but if we have to do more, we stop. We stop because open surgery has a role from medium sternotomy, or even more from left thoracotomy, which is a type of procedure not much adopted, but that is the procedure through which we can fix definitely the problem of the patients.
Okay. So more complicated scenario. They have malperfusion, whatever it is, left kidney, for example. Now you're going to do an intervention. Life was easy when you had a tube graft. Now we got a TBE and we got a Cook dissection graft. How do these new devices fit into your armamentarium of how you're going to treat these patients?
I gave some disclosures in the beginning of my presentation. I'm a consultant at SAM. I think that all of us knows more some materials and less others. I think that's at least is our experience. We've been working for 20 years with Gore Medtronic devices, and we believe that, for example, that these two stents can be enough to fit the problem. However, Cook and Terumo Aortic have excellent material, and we approach them. What is the difference is the uncovered stent in the thoracoabdominal section. So in that case, we go for the section Cook stents. Let me say that the last malperfusion patient that we managed was 3 weeks ago, 28 years old patient that did not solve after 2 TIVR, starting from zone 2, and then we had to use an uncovered stent, and the reason why this patient survived to this horrible malperfusion is because we used the IVUS. IVUS saved the life of the patient because the guide wires looks both one in the true and the false lumen. They were both in the false lumen. So please take in account that IVUS is really useful in this setting.
All right, I think we're right on time, and we're going to invite Dr. Mansour to come up and introduce the president. Thank you very much indeed for coming over here and doing that.